Neck pain is one of the leading causes of disability worldwide, affecting millions of people each year. Among the various causes, cervical radiculopathy stands out as a common and often debilitating condition. This disorder typically results from either a herniated disc or spondylosis, both of which can compress nerves and cause radiating pain down the arm. Impact on daily life can be significant, with sufferers experiencing not only pain but also problems with concentration, sleep, and even basic activities. As the global burden of neck pain continues to rise, understanding the best treatment options for cervical radiculopathy becomes increasingly important. Today, we'll explore the latest evidence comparing surgical and non-surgical approaches. Cervical radiculopathy refers to pain that radiates from the neck into the arm, following the path of a nerve root. This pain is often accompanied by numbness, tingling, or weakness in the affected arm. The two main culprits are disc herniation, which tends to cause sudden symptoms, and spondylosis, a degenerative process that develops over time. Diagnosis typically involves clinical examination and imaging, such as MRI or CT scans, to confirm nerve compression. Recognizing the specific cause is crucial, as it can influence both the course of the condition and the choice of treatment. Cervical radiculopathy can affect adults of all ages, but it's most commonly seen in people between 20 and 65 years old. In the recent Oslo University Hospital study, participants were outpatients referred for disabling arm pain lasting at least 3 months. Most had significant neck disability and moderate to severe arm pain. The majority also showed clinical signs like sensory deficits or a positive Sperling test. These patients represent a typical cross-section of those who seek medical help for this condition, highlighting the real-world relevance of the study findings. Address the question of whether surgery or non-surgical care is better for cervical radiculopathy. Researchers conducted 2 randomized clinical trials. One focused on patients with disc herniation, while the other included those with spondylosis. Each participant was randomly assigned to receive either surgical treatment, specifically anterior cervical discectomy and fusion, or a structured non-surgical program involving physical medicine, rehabilitation, and physiotherapy. The primary outcome was the Neck Disability Index (NDI) score at 12 months, a measure of how much neck pain interferes with daily life. Trials enrolled 180 patients in total, 89 with disc herniation and 91 with spondylosis. All participants had disabling arm pain for at least 3 months and a high Neck Disability Index score. They underwent thorough screening, including clinical exams and imaging, to confirm the diagnosis. Importantly, patients with signs of spinal cord involvement were excluded to ensure safety and focus on nerve root compression. This careful selection helps ensure that the results apply to the typical patient seen in clinics. Surgical treatment consisted of anterior cervical discectomy and fusion, a standard procedure performed by experienced neurosurgeons. This operation removes the problematic disc or bony growth and stabilizes the spine using a titanium cage. Most surgeries were performed at 1 level for disc herniation and at 1 or 2 levels for spondylosis, depending on the extent of disease. Patients received pain management and physiotherapy support before and after surgery. The goal was to relieve nerve compression and restore function as quickly as possible. Non-surgical approach was a structured, multidisciplinary program. Patients attended 6 sessions over 3 months, split between physicians specializing in physical medicine and physiotherapists. The focus was on education, coping strategies, and functional rehabilitation. No additional pain medications or steroid injections were provided. Instead, the program emphasized staying active, managing muscle pain, and reducing fear of movement. This approach reflects current best practices for conservative management of cervical radiculopathy. Primary outcome for both trials was the Neck Disability Index (NDI) score at 12 months. The NDI is a patient-reported questionnaire that assesses how neck pain affects daily activities, including pain, headaches, concentration, reading, and sleep. Scores range from 0 to 100, with higher numbers indicating greater disability. A change of 15 points is considered clinically meaningful. This tool is widely used and validated, making it a reliable measure for comparing treatment effectiveness. The disc herniation trial, both surgical and non-surgical groups improved over 12 months, but surgery led to a greater reduction in NDI scores. The average improvement was 7.4 points better for surgery compared to non-surgical care, a statistically significant difference. Patients who had surgery also reported less arm and neck pain, and a higher proportion felt their symptoms had improved. However, it's important to note that even non-surgical patients experienced meaningful improvement, highlighting the potential for recovery without surgery. Patients with spondylosis, the story was different. Both surgical and non-surgical groups showed improvement in NDI scores at 12 months, but the difference between them was small and not statistically significant. In other words, surgery did not provide a clear advantage over non-surgical care for these patients. Secondary outcomes such as pain and emotional distress were also similar between groups, with only minor differences. This suggests that for spondylosis, conservative management may be just as effective as surgery for most people. Beyond the main results, the study also looked at secondary outcomes like pain intensity, emotional distress, and work absence. In the disc herniation trial, surgery led to greater reductions in arm and neck pain. In the spondylosis trial, outcomes were similar regardless of treatment. Some patients in the non-surgical groups eventually opted for surgery, especially in the spondylosis group. However, these crossovers did not change the overall conclusion. Importantly, there were no serious adverse events in either group, supporting the safety of both approaches. While these trials provide valuable insights, there are some limitations to consider. The study was conducted at a single hospital in Norway, which may affect how well the results apply to other settings. There was no sham surgery group, so patient expectations could have influenced the outcomes. Some patients crossed over between groups, particularly in the spondylosis trial, which could introduce bias. Finally, distinguishing between disc herniation and spondylosis can sometimes be challenging, and the classification was not externally validated. Patients with cervical radiculopathy due to disc herniation, surgery may offer a greater reduction in neck-related disability at 1 year compared to non-surgical care. However, many patients in both groups improved, and non-surgical treatment remains a valid option, especially for those who prefer to avoid surgery. For spondylosis, the evidence suggests that conservative management is just as effective as surgery for most people. These findings can help guide shared decision-making between patients and their healthcare providers. Additionally, many patients have been told that surgery is necessary to decompress the nerve root and relieve pain. However, these trials challenge that assumption, especially for spondylosis. The results suggest that a structured multidisciplinary non-surgical program can be highly effective, and that surgery should be reserved for select cases. As surgical rates continue to rise globally, these findings highlight the importance of careful patient selection and consideration of all available options. Summary: the latest evidence from 2 rigorous clinical trials shows that surgery offers a modest benefit over non-surgical care for cervical radiculopathy due to disc herniation, but not for spondylosis. Both approaches are safe and lead to significant improvement for most patients. The choice of treatment should be individualized, taking into account patient preferences, the specific cause of radiculopathy, and the potential risks and benefit. As research continues, these findings will help shape best practices for managing this common and challenging condition.